Hello, everybody. As you're starting to join, I'm going to give everybody's audio the opportunity to connect, and then I'll welcome you to this session. So in about 5 more seconds, I'm going to say welcome. So many people are still connecting. It's so great to see so many attendees here for this panel. Great. Welcome, everyone, to the virtual Compassion in Action Healthcare Conference. I'm Casey Cadesia, Member Experience Advisor at the Schwartz Center for Compassionate Healthcare. On behalf of all of us at the Schwartz Center, we are so happy that you've joined us for today's panel discussion, Prioritizing Emotional Harm and Exercise in Humility. Please join me in welcoming our presenters for this session. Emily Rogers is the Operations Manager for the Simulation Center and Chair of the Schwartz Rounds Program at Children's Minnesota. Joining Emily is Alex Heisel, Manager of Experience and Health Equity at Children's Minnesota, and Lisa Shefty, Health Equity Specialist and Manager of the American Indian Community Collaborative, also at Children's Minnesota. Thank you all so much for joining us today. Emily, Alex, and Lisa, I'll turn it over to you.
Thanks, Casey. It's an honor to be here with you presenting at the Virtual Compassion in Action Healthcare Conference. As she said, my name is Emily Rogers. I am the chair of the Schwartz Rounds program at Children's Minnesota and your moderator for today. I am joined by 2 amazing women who will be our panelists today. Alex Heisel is the Manager of Experience and Health Equity at Children's Minnesota. Alex leads organizational efforts around the equitable delivery and exceptional patient and family experience initiatives, while also working to address organizational disparities in health outcomes. Alex has a graduate degree in learning and organizational change from Northwestern University and is a certified organizational leadership coach. She leverages her experience in change management, coaching, quality improvement, and patient safety to design strategic, sustainable change. Alongside her is her colleague, Lisa. Lisa is a health equity specialist and American Indian Community Collaborative Manager at Children's Minnesota. She specializes in system change by partnering and leading efforts to institutionalize health equity within our social work and quality and safety departments. Lisa also has co-created with community leaders the American Indian Community Collaborative and has launched 2 community and patient experience initiatives, The First Gift and the American Indian Volunteer Cohort Centering on Equity. The 2 of them have done some amazing work over the past couple of years in the realm of respect and dignity, both with our patients and families as well as our colleagues, and have been great partners in our well-established Schwartz Rounds program, and I can't thank them enough. I'm just going to give you a quick overview of our organization. Children's Minnesota is the 7th largest pediatric health system in the United States and the only health system in Minnesota to provide care exclusively to children from birth through young adulthood. An independent not-for-profit system since 1924, Children serves kids throughout the upper Midwest and at 2 freestanding hospitals, 12 primary and specialty care clinics, and 6 rehabilitation sites. Additionally, Children's is Minnesota's only level 1 trauma center inside a hospital dedicated solely to children. In 2018, Children's Minnesota was also verified as a level 1 children's surgery center by the American College of Surgeons. Children's maintains its long-standing commitment to the community to improve children's health by providing high-quality, family-centered pediatric services and advancing those through research and education. This work is really made possible by our amazing employees, professional staff members, and in large part by generous philanthropic and volunteer support from both organizations and individuals throughout the state and region. An award-winning health system, Children's received magnet recognition from the American Nurses Credentialing Center in 2018 and is regularly ranked by U.S. News & World Report as a top children's hospital. You can visit childrensmn.org to learn more. Our session today will be on prioritizing emotional harm. We define emotional harm as when we fail to treat each other with the respect and dignity we all inherently deserve. We're going to talk today about our journey in defining, analyzing, and learning from events of emotional harm to create a safer space for our employees and patients. And with that, I'm going to turn it over to Alex to get us started.
Thanks, Emily, and thanks for having us. Thanks for the interest in this topic. I can say on behalf of both Lisa and I, we're honored to share a little bit about the work and the journey that we've been on for the last two years. But I will say that I just have to start out by giving a huge shout out to Beth Israel Deaconess Medical Center, who presented a similar conversation a couple years ago at a conference I went to, and whose work I think has really been helpful in helping shape our in how we framed it at Children's. And so they've been incredible thought leaders, and just want to recognize Dr. Sokol Hessner and Pat Focarelli there, because they've really been leading the way in emotional harm, and so this work is really a tribute to them, and as we're trying to spread that good work. I'm going to be, usually I don't try to fight the sun, but I'm going to fight the sun that's coming in my window to try to not, so you can still see my face. But hopefully today we're going to just frame up a couple of things that we've been learning. One, a framework for assessing and tracking emotional harm in a healthcare setting, defining what that is, and some mechanisms that Lisa and I have employed for learning from those events. Outline the importance of naming structural racism as a foundation for emotional harm, and where we started on our journey, and hopefully giving you some tools for implementation as you go back to your home organizations today, and give you some food for thought. And I think through it all, just remembering that we love questions, we love kind of an informal dialogue. This is my first presentation in the outside of Children's in the throes of our pandemic, and so engage as you would in person. We'd really appreciate it with open questions and dialogue. I think we all learn better that way. So we wanted to start out and just share a little bit about how we got here and how we got to starting to track emotional harm and what we call events of respect and dignity. And it really started a little over 2 years ago when a lot of stars aligned at the same moment. One was the presentation that I mentioned around emotional harm. At the time, I was doing a lot of patient safety work in our quality department, but a lot of conversations were happening around how do we track and assess when there may not have been physical harm, but emotional harm that occurred for patients and families. Similarly, Lisa Shefty was hugely integral in pulling together a Health Equity Council at Children's on our late but important journey of understanding equity in healthcare, and really trying to figure out how we place the same importance on disparities in care and health inequities, the same way we talk about physical harm, and where can we identify that and learn from those events, all under the same umbrella when our Chief Medical Officer, Dr. Emily Chapman, really recognized that in order to continue our culture of safety and create teams and systems that are reliable, we have to have a place that we talk about psychological safety, or when our teams don't show up the best they could to deliver really reliable care. And so because of that, we really focused on creating a mechanism within our safety learning report system, what we call our incident reporting system, safety learning reports, to capture some of this, to look at it the same way that we might with the lens of physical harm. If you want to go to the next slide, Emily. And so why focus on respect and dignity? I think we, a lot of the story on how we got there highlights the importance of it. But I also think we acknowledge that while we have a lot of rigor around what we might call a central line associated bloodstream infection, we know that a lot of the emotional ways we show up for each other really impact how we show up at work, how we show up for patients and families, and really impacts the outcomes we provide. And so having a place that we stress the importance of and highlight as a way to capture that, I think was a really turning point in our journey at Children's. One, because we know that employee engagement is definitely impacted when we have poor teamwork, fractured teamwork. We have retention rates that are poor when we don't focus on how disparities or structural racism shows up in our teams, and also how that experiences patient and family experience, and like I mentioned, at the end of the day, how it impacts the outcomes, the clinical outcomes that we provide. And so one story that I really that really struck, I think, both Lisa and I when we first started to capture these events was one of our first reports was a nurse sharing a story about how she came into a patient room and was having a conversation with a mom who was just distraught after overhearing some staff members talking about how disappointed they were with her as a mother. And I think when we fail to recognize that those emotions and that emotional harm, it certainly has an impact on how that mom not only shows up in our system and the care that we provide, but also how she's feeling about the care she can provide her own child. And we have to own that, and we have to own those events to learn from and use the same system and interventions that we would for a patient safety event. And so I'm going to turn it over to Lisa to just talk a little bit about how we really rooted this endeavor in structural racism and what we know about health.
Hello, everybody. Thanks for the intros. Children's Minnesota, I just want to do a land acknowledgement. Children's Minnesota is on the Dakota land of Native people here in southern Minnesota. I'm Anishinaabe from northern Minnesota. Those are my ancestral homelands. And just wanted to let you all know whose land we reside on. When I first came to Children's, healthcare seemed to be catching up to what makes an individual healthy. And part of that is understanding social determinants of health. And a lot of healthcare institutions are kind of find themselves in a predicament of not really understanding how might they influence social economic factors, how might they influence physical environment around their hospitals. Children's Minnesota is located in one of the most diverse communities in Minnesota, and our patient population is our inpatient population is somewhere 54% kids of color, and in our Gen Peds Minneapolis clinic as high as 74%. So the kids that are who come to Children's are from diverse communities, and the communities that our hospital serves is in the backyard of very diverse communities. So when a healthcare institution first begins to want to impact health, one of the things that we realize is that the actual healthcare institution only makes up around 20%. And we like to start here because what else can we do? What, as a healthcare institution, how can we push further? Next slide, please, Emily. And in order to really understand the fabric of like what makes someone healthy, we also need to get clear on some definitions. And for this, we borrowed these definitions from the Center for Social Inclusion. And a lot of our work, we focus mostly on institutional racism and structural racism. I kind of use these terms interchangeably, but when we're talking about internally at Children's, we are talking about policies, practices, and procedures that work better for white people than for people of color, often unintentionally or inadvertently. And structural racism is those historical practices of racism that has been combined to create this system and has negatively impacted communities of color. And in order to ground us, one of the, this TED Talk from Dr. Williams, oh, sorry. I just got a echo. This TED Talk from Dr. Williams is really helped us at Children's build a blueprint when we were start talking about healthcare disparities, structural racism, and he really gave us kind of like a blueprint that we can measure structural racism in point of care. And in order to do that, we need to get really clear and honest about the fact that majority of our patient population are kids of color, yet we hardly hear from them. We don't have good mechanisms to learn about their patient experience and then to take that leap and connect that patient experience to patient outcomes in a very clear, responsive, compassionate way is the goal. So we're gonna hear a snippet from this TED Talk, and if you have time, we recommend that you listen to the entire thing. And I've heard it like 100 times, and each time I learn something new.
Why does race matter so profoundly for health? What else is it beyond education and income that might matter? In the early 1990s, I was asked to review a new book on the health of Black America. I was struck that almost every single one of its 25 chapters said that racism was a factor that was hurting the health of Blacks. All of these researchers were stating that racism was a factor adversely impacting Blacks, but they provided no evidence. For me, that was not good enough. A few months later, I was speaking at a conference in Washington, D.C., and I said that one of the priorities for research was to document the ways in which racism affected health. A white gentleman stood in the audience and said that while he agreed with me that racism was important, we could never measure racism. We measure self-esteem, I said. There's no reason why we can't measure racism if we put our minds to it. And so I put my mind to it and developed 3 scales. The first one captured major experiences of discrimination, like being unfairly fired or being unfairly stopped by the police. But discrimination also occurs in more minor and subtle experiences. And so my second scale, called the Everyday Discrimination Scale, captures 9 items that captures experiences like you're treated with less courtesy than others, you receive poorer service than others in restaurants or stores, or people act as if they're afraid of you. This scale captures ways in which the dignity and the respect of people whose society does not value is chipped away on a daily basis.
So Dr. Williams said, racism feels like your respect and dignity is chipped away on a daily basis. And I think that when at Children's Minnesota, also we've named structural racism as a priority health issue impacting children. And we named that in our community health needs assessment in 2016 and also in 2019, because what we're trying to do is take that next step and go beyond just talking about social determinants of health and really connecting the fabric on how policies, practices, how historical policies and practices are impacting kids of color and their health today. So I'll let Alex take it away.
Yeah, and I think that's just been such a fundamental aspect of how we've brought this into our organization, is that you know, our charge is to foster a culture where everyone's treated with the respect and dignity, because we know it's the natural progression of advancing patient safety and quality in medicine, and how we treat each other directly impacts the outcomes of the care that we provide. And so that's a great idea. And I think, you know, Lisa and I have really rooted the work that we've done in a lot of what Dr. Williams says, which is, you know, how can we measure this? How can we put some of the data that we know a lot of healthcare institutions are so hungry for to measure this and to address the systems that we know impact our care? And so to do that, if you want to flip to the next slide, Emily, you know, we really tried to mirror this towards our physical harm assessment in our organization, that while we have a really robust system for detecting and evaluating physical harm, our process for detecting and evaluating emotional harm really is lacking and non-existent at the point that we really embarked on this journey. And so through some thought processes and some brainstorming, we, if you want to go to the next slide, Emily, really committed to naming what we thought was emotional harm, which is when we fail to treat each other with the respect and dignity we all inherently deserve, and putting some structures in place for us to learn from those events in a similar way from physical harm. And so to do that, in the next slide, this is our safety learning report system. You may look similar to examples at your own institution. But we committed to, in that bottom left-hand corner, creating a category for respect and dignity. So people could report events of emotional harm. And we left it really broad when Lisa and I brought this to the organization. We use that definition of emotional harm, but we also said it's when something just doesn't feel good in your gut, or you feel like we could have done better, or the treatment wasn't the same for this patient as it might have been for somebody else. To let us know, just like you would if you felt something could be more efficient or more safe in a clinical care process. And so the form to the right is really the form that we ask our submitters to fill out, and we ask who was involved, you know, who was impacted by this event. Was it a patient? Was it a family? Was it you as the employee because you felt like our teamwork wasn't great, or you felt disrespected? And giving a brief factual description, which we ask for in all of our events. And then we have a process to go through those events and code for certain themes so that we can learn from them. And we'll walk you through a little bit more about how we categorize that in our at Children's. If you want to go to the next slide. So like I said, this conversation really started about 2 years ago in August of 2018, and you can see the number of safety learning reports submitted by month. These are just our respect and dignity safety learning reports. And you can see the light blue is the person impacted was a patient and family. The dark blue is an employee. And right about September of 2019, where you can see that big jump up, was when Lisa and I went and made a pretty deliberate effort to communicate this to the organization on more broader scales. Up until then, it had kind of been word of mouth, and we just had the category as an option in the system. But I think, you know, being in the midst of you know, the Schwartz Center and people who are really passionate about taking care of caregivers and employees, we really saw that this was a need for our institution. People definitely understood when we talked about structural racism impacting the care that we provided patients and families, but it also felt like employees really had a desire to talk about where we didn't show up for each other well as a team. And so you can see our numbers. We pulled this in July, so we have a little bit more recent data, but we're on track to have just as many submissions this year as last. In a year that we've definitely seen lower volumes, as I'm sure many of you have across your organizations as well. So we're actually pretty impressed that we've maintained that number. And just to give an idea, we get roughly about 500 SLRs a month. And so we're pretty proud that a big chunk of these are respect and dignity events, and feel like it's fitting a need at our organization. So, so what do we do after we collect these? Kind of what's the process? So I'll talk a little bit about the beginning of the process, and then Lisa can share how we've incorporated a lot of equity principles into it. I think, you know, we receive these SLRs, you might have to click through, Emily, that are reviewed. You know, we assign them out like any other incident report to a file owner for that individual to look at and learn from. But we also review them as a small team and go through a process by which we assess emotional harm and determine how, for a reasonable person, how you know, and this is part of our learning, emotional harm is really hard to assess, but how much emotional harm did it cause, right? Are they leaving our institution? Have they asked for their medical records to be retracted so that they can use them elsewhere? And then how likely is it that that event could happen again? And then we have we've gone through a couple iterations of how we identify themes, but what are we seeing? How can we put some of these into a bucket to say, gosh, we're seeing a lot of opportunities around, you know, calling CPS for patients, and is that disproportionately impacting our families of color, and when is it happening, and how can we work to identify what systems are contributing to this inequitable care? And then we do case reviews similar to, I'm sure many of you at your own organizations, to a patient safety event. We walk through and look at the contributing factors to that event. And again, I would just shout out to Beth Israel for creating a mechanism for us to learn how to do that. But then we share it with a group of about 25 people who have been asked to be a part of this group to identify some of those systems that need to be addressed that contributed to the emotional harm in this case. But before we go through that case review, Lisa, in her brilliance, I think, has created a structure for us to start by centering on our power and privilege. And so I'll just let Lisa talk through a little bit about this forum that we use before every case review every month.
Hello, everyone. So this forum was co-created with American Indian community social workers, guardian ad litems, social service workers, ICWA attorneys, Indian child welfare attorneys. And what we did was we had an open group that would come into children's, all American Indian, all facing or doing or dealing with children who are in the system, American Indian children who are in the system. And they came every month, and we decided to start an equity case review. So every month, the social workers get together and they talk about a case. And our social workers, along with our American Indian community social workers, really wanted to ground in understanding how bias, power, race influences the decisions you make, and to route it. And in order to get to that point, we developed this facilitator guide, a prep form that's really about, before you speak about a patient, you have to kind of go through your list of who you are. How do you see the world? How do you interact? But then once you've gotten used to it, because a lot of folks, so our social work, our professional staff at Children's is a really homogenous group. They're white, master's degree, clinically trained, upper middle class, upper middle class. They've all are able-bodied. They're cisgendered. They're heterosexual for the most part. And so when they're going through their lenses, they state this every single time. They have to state this. And then at the end, they talk about the historical intersections with racism purposely. So either they'll tell a personal story about how they grew up, derogatory names of other groups that were spoken in their home. They will talk about any biases that they might have that might influence the case. So if we're talking about misgendering, they'll speak to the first time they've ever misgendered somebody, or the first time they've learned about anybody other in their families, in their lives. And so a lot of the social workers, one of the biggest things that we'll do is like, do your work, know who you are, where did your people come from, how long have they been residing in Minnesota, what was the first exchange of native land in your family, do you know that story? how many years have you been homeowners? How many years have you had stable housing? And I remember one of the social workers, when it got to social economic status, she got choked up because it was the first time, like, she realized that she never has to speak about her economic status because she has enough stability that she does, no one ever asks her, if you have a need, what's your need? And you have to state it. And she grew up in a household where you don't speak about money. And so suddenly it was very hard for her to, it was one of those moments that, and that's what we're always trying to get folks to, is where is the discomfort and how you talk about something, and also connecting that discomfort to how do families talk about it. And for her, that was a big moment because she realizes that, like, in order for families to get a food need, a housing need, something, they have to declare their need. And then just walking through the process of, like, how vulnerable is that? What are some biases that I have around needing a food, having a food need or a housing need? So part of this is just, one, it's kind of, I always say that I don't really, in my work, I don't focus on individual biases or individual racism, but in order to get the team of social workers collectively to a moment where we can start identifying how bias shows up in patient care interactions, we had to do the work of walking through with somebody and being vulnerable enough with somebody to speak on what are their biases. So, like, if a social worker had an interaction with a Native family, when they're discussing their historical interactions with racism, they might concentrate on what did they know about American Indian folks prior to this. And they'll talk about going to cowboy and Indian parties, bonfires, drinking, having these costumes, and they'll state it, and then after they state it, they are vulnerable, they recognize that vulnerability. We try to get them to talk about what made them uncomfortable, because that's where we know an undoing bias is. We have to recognize what makes us a little uncomfortable. And then once they get there, then they start talking about the case. And some of the questions involved in the case review are, what is the power? What is the perceived race of the family? So in Minnesota, we got a reputation for being Minnesota nice. And, the racial disparities in atmosphere in Minnesota really are devastating, because in Minnesota, folks don't talk about race, they don't acknowledge it, they don't see it. And this colorblind racism perpetuates inequities in care. So we don't need folks to say, I don't see color. We need people to say, I recognize who you are, and I believe what you say, and I acknowledge your who you are. And so, like, even for, Minneapolis, the Minneapolis Children's Hospital is 10 blocks, not even 10 blocks. Yeah, 10 blocks away from where George Floyd was murdered. 10 blocks. And when I heard community members speak on what happened to George Floyd, and then speak on what happens inside of our hospital, there's such a disconnect, because folks don't believe the experiences of people of color, Black folks, Native folks in Minnesota, because a lot of the people who are making power decisions don't reflect this community, right? So they're a homogenous group. And in order to do that work, we have to get folks talking about who they are. Who are your people? Where did they come from? How long have you been in Minnesota? These are such important questions to beginning to understand, what was your flight? What was your privilege? Do you have privilege? Can you recognize it? And then when you get to do that work, then we can start talking about, how does your bias, influence, power, race impact the decisions that you make on a daily basis for communities of color? And I think that's my spiel. And so we're still doing all of that work, and we do, not only have done that work with social work, we've incorporated it into our respect and dignity process. So the same case review is applied to every single time we get together and we talk about these cases. We identify where potential are the biases, and then are there potential system level changes that we can apply, knowing that systemic racism, disparities at point of care are being influenced and perpetuated by what we see, what we know, or what we don't know, and what we don't see as a system. Thank you, Emily.
Yeah, thanks, Lisa. And I think that, and that's what I would say has been one of the factor, I mean, the most important factor for how we've been able to move this work forward is by grounding in that power and privilege that we hold. Then it's easier to see where the structure perpetuates that power and privilege, so that we can identify where we need to put different systems in place. This is just an example of one of a report that we received around misgendering a patient. A patient came into our system identifying as they, them, their. Preferred name was not updated at the time of the last visit. Our medical assistant called the child he, and the mom was upset. We were able to update the preferred name in the chart, but per the mom, it was supposed to have been updated a while ago. So again, a system opportunity that we don't have that serves our transgender patients and using their preferred pronouns. And so looking at this, looking at how we use our banner bar or our identification labels to think about how we can better serve these patients and the significant emotional harm that we cause when we don't center those needs. But I think of a lot of other examples around race that we continue to have, to Lisa's point, particularly going into this pandemic and having strict visitor guidelines, but when we have visitor exceptions or compassionate exceptions, we've seen disparities in when we make those exceptions. And so if we are looking at our system, anywhere we have subjectivity, bias is likely to live. And so are we giving those compassionate exceptions are we having less compassionate exceptions for patients of color and families of color because of the structures that we know are in place because of institutional and structural racism? And so thinking through, then we look at the systems to create accountability, to then measure race, ethnicity, and language data for those exceptions, and creating the visibility to see where the disparity exists. So I know we want to leave some time for questions, but I think we have just 2 more slides about what we're learning. Like we said, we're very much in the midst of this journey, and we iterate and adjust as we go. But I think a couple of the key points that we've learned is, one, that this is the physical harm journey revisited, right? The 1999 Institute of Medicine report, when we came out and really started our patient safety journey, our emotional harm journey, and how that directly relates to health equity and disparities in care is the same. We have to collect the information in a way that helps us use data to highlight the issues, but then focus on the system, which I think is, the number 4 learning is, we partner really closely with our equity and inclusion team, but Lisa and I have always stressed that our systems produce these results similar to a medication error. How do we look at the system and make the changes and keep accountable for those changes? We can talk more about partnering with HR early, but obviously when we're collecting events around employees' emotional harm, I think having a close connection with the HR and understanding those processes to make sure they're followed, but also relying on leaders to understand when we need to engage HR and when we really need to focus on those system opportunities. And then I'll just quickly highlight some of our hopes for the future and let Lisa kind of to tie us up. But what I think we are both hopeful for is that you know, that we would start to catalog and own emotional harm the same way that we own some of our serious safety events or physical harm events. And with that, you know, we're still learning on how we create more rigorous structures and actually identify emotional harm in a way that feels like we can have some definition and rigor behind it, but also understanding that it may not be, you know, to the video's point, you know, we can define things that feel like it's a little bit more squishy or mushy. And then I think continuing to refine our case review protocol, and I'll just let Lisa wrap up with any of the other hopes that she wants to.
Yeah, so, and I don't know if we've stressed this enough, but like, we want to review these events through race, ethnicity, and language data, and even if we can, to push it further to zip code and insurance type, so that we can also say, we can look at these events of respect and dignity and harm, and then to say, do we have disparities based on race, based on ethnicity, based on language? So that way, it can we can give a new voice to families and patients, and really talk about the experiences that we're not doing a good job at capturing. And for instance, looking at the themes that we're seeing in respect and dignity, and then saying, being able to make informed decisions to say, these events that are impacting communications seem to be largely impacting Black patient experience. How can we be then taking what we've learned from respect and dignity and system change to applying it to how, when we're designing a new Gen Peds experience, how can we really push folks to talk about Black patient experience and the impacts specifically? So we want to use this work in order to highlight disparities that are impacting populations who we seek to eliminate them with. And we can't do that unless we have, unless we're able to collect this emotional harm and then to use it in a way to change the system. And then that's it for me. And I'm going to catch up to some of your comments in the chat and the text while we start the Q&A portion.
Yeah, thank you, Lisa. I know there's been quite a few comments coming into the chats, and we really appreciate it. The one call out I will make is acknowledging Lisa for making that comment at the beginning about the land that Children's is on. I think that I remember the first time I heard you mention that in a meeting, and I was like, how powerful is that, that we need to recognize that. And so a couple of people also commented about, like, I've never heard that, like, that's so important. So thank you for doing that. A couple of other comments, just I love this one from Randy about the pronunciation of names, right? Talking about Kamala Harris's name and how, you know, sometimes we're so used to the same that it's hard when all of a sudden we're being asked to try something new, right? And I think that that's extremely powerful to acknowledge. So thank you for that comment, Randy. One question that I did see come in here from Jody, it says, congrats on the great project. Could you please discuss what the process is for patients who report, i.e. in writing, online, in person? Since your team isn't racially diverse, do you think you could have more patients report if it was?
Yeah, I think this is a great question, and I'll start us off, and then Lisa, please chime in. So currently our process is that it is employee driven, and when we presented it out to the organization, it was really a plea to say, when you're hearing this from families, right, that this is your way of elevating their voice, so that we look at it. But currently, and it's a question that we get, that we've received a few times, is how can we create a space for families to do the same? And I saw another question come in about how patient experience kind of ties into this. I have the privilege of looking at our patient experience data too, as well as these reports. And the information we get is really very different what we hear from the same family, you know, we hear an experience that they had potentially reported by an employee. And oftentimes I don't think the family feels safe enough to share that experience or don't have time. I mean, there may be a lot of reasons why they don't share it in our patient experience survey, which we do break out by race and ethnicity to answer that question as well. But I think it's something that we have to grapple with and get creative with, because I do think there's an opportunity for us to engage in the patient voice more rather than just rely on the conduit coming from the employee. I don't know if you have anything else to add.
Yeah, I guess I would just say also too is I see the other question about repairing harm or formal apology and partnering with spiritual care. So like in my work, I do partner a lot with social work and also spiritual care. And in order to like, we also partner with risk. They have patient liaisons. And one of the key things I've learned from them is about service recovery. And so sometimes we don't hear about that event because it gets, the patient complaint goes routed through risk, or it gets solved, or we've done a great job at service recovery that we never as an institution hear from that event. But what I love about service recovery, especially when it's impacting patients of color, Native people, and Black people, is that it's an acknowledgement that something happened, that you were harmed. And I think that like as we're rolling out respect and dignity, we're trying to accomplish a few things. We're trying to get folks to acknowledge the experience that folks are having as an attempt to repair that harm that's done in the exchange, but also because this is not a patient, this is not a way that a patient can file a complaint, because if they were to file a complaint, it would be routed through a different stream at the hospital. But when it's a staff member who sees it, again, because it's Minnesota and folks are trained to think that racial discrimination has to be blatant. You have to use a derogatory term. You have to physically remove yourself. It has to be so blatant because no one can see it, because of that racial divide. And even for folks, people of color and Native people, we are trained not to see it. We're trained to accept this racism every single day in the form of this chipping away at the respect and dignity, right? So like some of my community, because I see patients too, they're not even recognizing this. They're used to the mistreatment, right? So like for me, I need someone with enough power and privilege of being treated well to recognize that this is not okay. The way this mother is being spoken to made me feel uncomfortable. And then when they file a respect and dignity then we look at it from the patient MRN number to say, what is the race of this child? Because I think we're gonna be able to get a lot more events that are telling us a story about patient experience of our diverse patients from a lens of folks who have a lot of power and privilege, who have the power and privilege to feel offended when they get mistreated. Does that make sense? And so like I love service recovery and the best, mainly because of an acknowledgement, just like the land acknowledgement, being seen, being heard. It can change how you feel in a moment. It can change how you talk to your provider. It could change how you go home and are able to retain your discharge information, because when I'm not treated well, I can't retain the same information, you know? So it's all connected. There's a lot happening in the chat box.
That's okay. And I wanted to apologize. I forgot to pull up the Q&A. So if you have questions, go ahead and throw them in the chat. But there was a couple in the Q&A also that came over. I know, Alex, I think you addressed one of these, but I have one that says, do you have a specific way to assess emotional harm, a list of things that you define as emotional harm? And I know we've kind of talked about this a little in our meeting, so I'd love to hear what you have, Alex or Lisa.
Yeah, I think this is one of the ways that we've continued to reiterate and iterate again. So we don't have something that the submitter needs to meet as a requirement for submitting a respect and dignity event. We say, when in doubt, fill it out, because if you're feeling like that gut, like it doesn't feel great, there's likely something for us to learn if you're feeling that discomfort. What we do on the back end is we have some categorizations that we used from the toolkit that Beth Israel pushed out around, was it discriminatory behavior? Was it condescending? Was it, was it around our safety and security practices? Was it, language or language access services? And so we try to kind of categorize those things again to theme and bring those forward to our executive leadership as opportunities for us to pursue. But our definition for emotional harm is really broad, and I think it's kind of the next step in our process is, how do we put the rigor behind how we would define emotional harm, so that when we have an event that's really egregious, that we own it and repair and recover with that family the same way we would for a physical harm event. I think it's a good question, and I know nationally there's a lot of people working on this. HPI, I know through Press Ganey is kind of working on developing an emotional harm framework that I'm really interested to see, but we're learning as we go. It's not a great answer to your question, but I think it's a good one.
I just have one more comment. When we first started this work, we did not have to overlay it with respect and dignity overlaid by race data, language data. That was an intentional effort to try to merge the work of like compassionate care, living our values, appeasing to our mission statement at Children's. It was intentional work to align that within an equity framework. And so for that, one of the tools I use all the time is a racial justice impact assessment. And I use a local one to Minnesota. It's called Voices for Racial Justice. And really what it is it's a tool that you can use to help make sure that whatever policies, programs, procedures that you're developing within your organization, you run that through a REA, a Racial Equity Impact Assessment, and that will help you try to sift out where, and my favorite question on that is, my favorite question is, it forces you to identify what population are we seeking to reduce harm, what population are we seeking to make the greatest impact around eliminating disparities. But then the other question I think is very useful is, what potential negative impact might I have on this population from this policy, this practice, this procedure? And in Minnesota, I have to add, what potential negative impact of your program, policy, procedure, even with good intentions? Like, I know they were developed in great intentions or the best of intentions, but is it possible that you could potentially have a negative impact on the group you're seeking to eliminate disparities with? So, and I would have to thank Alex and our quality and safety team for allowing that intentionality around incorporating equity lens into how we do this work.
Yeah, that's a great call out, Lisa. And as we wait for a couple more questions to get into coming through the chat, can you guys talk a little bit more about any challenges or pushback that you faced when we were implementing this into the organization? I feel like Lisa's already nodding her head, I see. So talking a little bit more about that, because we were about 2 years into this journey, and it's really become part of our culture and really been accepted, but it wasn't always like that, especially when you first start something. So talk a little bit about that.
Lisa, do you want to start out?
I feel like I'm gonna let you guide this and then I'll jump in.
Yeah, I think a lot of it is related to the questions that you all are asking, is like, how do you actually assess emotional harm? And is that, I mean, how could we assess emotional harm? That's so subjective. And I think we all get uncomfortable when we start talking about racism and putting a name to it, and how, you know, we have care processes that are really detrimental to our patients and families of color, Indigenous families. And so I think there were a lot of, I mean, you know, people said emotional harm. Oh, I don't like that phrase, you know, even calling it that. And so actually one of the pieces that we didn't hit on, and one of the factors that I think has been so crucial to our success, is executive leadership that just are unwavering in their support of health equity and what that means, and how you have to name white supremacy and white privilege and be comfortable talking about structural racism, and an executive suite that is just incredibly supportive of this work. And so, but I think that's where we initially ran into some challenges.
Yeah, and I think kind of echoing what you said, I was only half listening because I was reading I was trying to type in the RIA, but I think it makes a lot of leaders nervous because, and I think I've heard Alex speak on, like, when patient safety was first developed, it was a lot of folks being scared of, like, the finger pointing and accusing, like you did something wrong, and then folks are stuck in that shame and blame. And we still see that because we have a lot of leaders who don't want their staff to submit the respect and dignity report because they want to filter it. And I don't think that the filtering is bad intentions. I think that they want to solve. They want to provide some service recovery. But what we're trying to do is we need to know about those opportunities so that we can say, where is the greatest systemic opportunity to make the largest impact? Because although you want to solve that one day, one time thing that happened, there also is a bigger picture that we want to address, and we need that data, we need those reports in order to know where do we have the largest impact.
And I think that is an awesome spot to stop. So I want to thank Alex and Lisa for your amazing presentation today. I know I have the honor of working with you every day, but I still get so excited when I get to listen to you guys speak. So thank you so much. And we'll pass it back to you.
Yeah, thank you so much. What a wonderful workshop. We really appreciate your time today and for sharing your experience with us. We'd also like to thank our national business members. We are so grateful for your support, and we wouldn't be able to do this conference without you. And a special thank you to our audience for attending today's session. Please keep your eye out for a recap of this week's session and an email containing a link to claim your continuing education credits for today. We look forward to having you all back on Friday, October 16th for Improving Patient Experience of Care through Workforce Development, a workshop with Jenny Azara and Louise Koef-Weed from Community Care Cooperative, C3. Wishing you all a good rest of your week.